Thanks, Ben. So I get the pleasure of talking about the soft tissue part of really what's been an instability session this morning. And I don't know if Ben has actually been stalking me in my practice, but it seems like I have probably half of my clinic. Patients will come in and they'll say that they have EDS. And I think a lot of patients get diagnosed with EDS, probably overdiagnosed. It's probably one of the most overdiagnosed things that I see. That being said, Tom and I were just talking that I think we're both named on a Facebook or a Reddit group where if someone has EDS or they think they have EDS, they find certain doctors. So I'm sure a lot of the folks in this room have that exact situation in their clinic, and that's what we're going to talk about for the next few minutes. And so this is really hyperlaxity and EDS and an impact on decision-making in borderline dysplasia. And here are my disclosures. And so, as we all know, the definition of borderline dysplasia, the definition of instability, is incredibly heterogeneous. And there are dozens of different definitions, dozens of different terminology words that we use to describe really as what is an unstable hip. And so there have been attempts to try to define this better, but anything that has 35 different cells to define something probably isn't optimal. That being said, this is actually probably the best one that we currently have in our literature. And this is from the Microinstability International Expert Panel. This was actually published a couple of years ago. It has multiple different major factors, minor factors, to really come up and arrive at a definition of hip instability. And so they called it microinstability. Microinstability has been a word that we've used for this patient for over a decade. We actually published this picture 11 years ago, and it's a variety of different patient symptoms, physical exam signs, and imaging findings. And so the long story short with it, it's just extra hip range of motion. And so this is described as laxity, hyperlaxity, hypermobility, hyperflexibility, and that's very analogous to that of the shoulder. It's just extra range of motion for those words without symptoms. Once symptoms become involved, then it becomes microinstability, instability, or what we've also seen is hypermobile hip syndrome. And so if you look at this like we did with the Warwick Agreement and FAI syndrome, whenever you see a syndrome, it's the combination, it's the triad of an and statement of the patient's symptoms, their objective physical exam signs, and their imaging findings to come up with that diagnosis. And when you apply that to EDS, EDS can actually be laxity without symptoms, or it can truly be instability with symptoms. And so for the hypermobile EDS, that's the point of this talk. However, there are multiple different other kinds of EDS. There's 12 other kinds. There's 13 total. We don't yet have a genetic marker for hypermobile EDS. There's a group in South Carolina, Don Norris's lab, that's actually looked into this. They think they have found one, but it's not yet commercially available to test for. Which is why if you see a patient in the office and they are a typical hypermobile EDS without any vascular signs, ophthalmologic signs, cardiac signs, they don't need to be referred for genetic testing. But if they do have a family history, if they have any risk factors for it, then referring this to rheumatology or an Ehlers-Danlos expert would be warranted. And so you don't need to be sending all of your benign, generalized joint hypermobility patients for genetic testing. And so I think really the hypermobile EDS truly is a diagnosis of exclusion, and it requires meeting 3 separate criteria. It's not just extra range of motion. And so for generalized joint hypermobility, I think this is probably the most important slide that I want to convey. And so Bite score has always been the traditional kind of crude assessment of hypermobility. If they're less than 18 years old, it requires 6 or more. If they're between 18 and 50, it's 5 or more. And if they're greater than 50, it's 4 or more. This is twice as common in females than males, more common in young than old. And this bottom line here I think is important. Generalized joint hypermobility is present in up to 20% of just our general population. However, EDS is present in less than 0.1%, and therefore 99.9% of people with generalized joint hypermobility, the double-jointed flexible patient, 99.9% of those don't have EDS, which is why it's probably very overdiagnosed. But also, because it requires these 3 separate criteria, it's also probably underdiagnosed as well. And the second criteria is you have to have at least 2 out of these 3. And so it's a systemic manifestation of just a generalized connective tissue disorder or a positive family history. We think this is probably polygenic and is autosomal dominant, passed down through generations, or pain for a long period of time greater than 3 months or multiple joint dislocations. And the third criteria is you have to have actually all 3 of these. So you can't have skin hyperextensibility, that's your classical EDS, not the hypermobile EDS. You have to exclude other known connective tissue disorders, and you have to exclude other known hypermobility disorders. And so this is what classical EDS looks like. This is something where this is actually blatantly obvious. This is not going to be your hypermobile EDS patient. So they have a lot of basically skin hyperextensibility. Their scars don't heal. They are atrophic. And so if this is skin healing of the hip joint, so ligament, bone, cartilage is probably analogous to what you're seeing superficially here. And so for hypermobile EDS, you don't see that from the skin manifestations. And the joint range of motion is the hypermobile EDS. You don't require that in classical EDS. And so that's where you assess your Brighton score, you assess your hip range of motion. And so how do you use this EDS diagnosis in borderline dysplasia? As we know, as we've heard from the last several talks, surgical outcomes are variable at best when you're looking at arthroscopy versus PAO. The trend, I think, is pretty universally agreed upon now that PAO is probably the right answer in a large number of patients. But still, that being said, our literature still says if you do a meta-analysis of the best literature that's out there, there's no current gold standard. And so I think the decision-making, number one, it's not easy. And if you apply this to a talk that Tom Brady gave at the AOSSM annual meeting several years ago, why did he win all of the Super Bowls? And it wasn't just one thing. I think a reporter asked, what's the one thing you'd want to tell the audience? And he's like, it's never just one thing. And I think for borderline dysplasia, it's never just one lateral center edge angle, as Sanjeev said earlier this morning. So it's not just one. You got to look at everyone and look at all the different factors. And so indications for treatment, especially indications for surgery, they must truly fail extensive. And everyone's definition of extensive, I think, is different. But I think probably a minimum of 6 months of non-surgical treatment before you embark upon surgery these individuals, just because their chance of success is lower than those non-EDS patients. And it's got to be good non-surgical treatment as well. So they have to have high-quality PT. And so and statement versus an or statement. So if the patient's clinical picture, so basically their story, their subjective symptoms, plus their physical exam, plus their images, all point to impingement, then you could maybe consider a scope. But if their story or their exam or their images point toward instability, I think a PAO is probably the right answer. Or you can combine, as we talked about this morning. So I have a very low threshold to consider PAO in these individuals. And so their symptoms are going to be more lateral pain rather than anterior pain. It's going to be more weight-bearing symptoms rather than flexed and positional. They're going to have mechanical symptoms. The snapping you can hear is the psoas. The snapping you can see is their IT band. And if you really assess their gait, those that have an internal foot progression angle, look for femoral version, as we actually just talked about in the last talk as well. So excessive range of motion is the sine qua non of hypermobile EDS. And when you look at it in hip, it is truly all planes. But if you see a lot more internal than external, think femoral version, they usually have a very guarded, irritable hip physical exam. And so when you do instability, provocative maneuvers, extension, externalization, that's going to reproduce their symptoms that brought you to their, that brought them to your office. Going to be more lateral perception of impingement, and they're obviously going to have a higher Brighton score. The imaging checklist, as we've gone over, has multiple different dozens of items that we can look at. And these are a couple of different pearls that I've seen in my practice. We actually did this, we published this in a couple of different journals, and it's really something that is a three-dimensional problem assessed with two-dimensional images. You can still represent that with instability on what's called the splits view, where you literally have your patient do the splits and you shoot an x-ray of it. Their hip will actually come out of socket in about a third of patients. And so they'll create a vacuum sign. The hip will literally come out. It'll translate more than a centimeter. And so that femoral head translation is objective evidence of this. Look at also the size of your labrum on the MRI. The hypertrophic labrum probably is a sign that it's been protecting hip instability, but also the small labrum may not be enough, and especially an everted labrum up off the rim might not be enough to actually contain the head in the socket. If you do an arthrogram, you can lose the suction seal. I think if you inject 5 milliliters of contrast dye in your hip and you see the hip come out, that's probably a sign of significant hip instability. You can also measure the size of the capsule, see if the capsule actually has a hole in it, is fluid extravasating from the capsule. Look for the hypermobile hip crevasse. This is actually a legitimate objective sign of instability where the head is levering out. This could be anterior, it could be posterior, and you'll see a variety of different findings at the time of arthroscopy. If you're going into the operating room, I think an arthrogram is actually really valuable to assess how much instability is truly going on. You can get up to 35 milliliters of air in someone's hip, as you can see here, defined by your zona. You can also see an AR arthrogram truly just break the seal with less than 5 milliliters of air going in, which probably shouldn't happen. This is a video that I actually got from the group at Iowa showing real hip instability at the time when they did a scope PAO. You can measure this with some companies' systems. You can actually measure the force of distraction, the amount of Trendelenburg of the bed, and the amount of femoral head translation out of the socket. And I think that's a definition of truly hip instability. At the time of arthroscopy, the group in Colorado has really shown outside in versus inside out lesions might be a predictor of either cam impingement causing this or dysplastic instability causing this. The outside in is going to be the cam. The inside out is the shear force that you see with dysplasia. And so if you do an arthroscopy in this situation, make your cut big enough to see, but no bigger. And so periportal, if that's something that you can do a periportal, or if you make an interportal, it doesn't need to be any bigger than 10 millimeters. Don't make them more dysplastic. Preserve the soft tissues, including the labrum. Don't cut the psoas. Don't debride the ligament and teres. And if you open the capsule, you should close it when you're all done. And so I think just like hypermobile EDS is a diagnosis of exclusion, I think arthroscopy in this situation is a treatment of exclusion and a real low threshold for the PAO. And so just because they're hypermobile doesn't mean they're unstable. Not all hypermobility is EDS. In fact, most of it's probably not. Non-surgical treatment is your primary treatment. Arthroscopy is a treatment of exclusion and have a low threshold for your PAO. Thank you.
And the last talk of this session,